Today I'm going to be speaking about neoadjuvant therapy for breast cancer. As in the lovely introduction, I'm a medical oncologist from Newcastle, Australia, and I have a number of roles in addition to my clinical role. I am a conjoint senior lecturer at the University of Newcastle, and I work as a medical advisor at Breast Cancer Trials. And Breast Cancer Trials is the primary collaborative trial group within Australia and New Zealand, and we conduct a range of different trials in a collaborative setting throughout sites in Australia and New Zealand with international and national partners. This is going to be an overview of neoadjuvant therapy for breast cancer. I'm a medical oncologist, so naturally I think about chemotherapy, but I will endeavour to touch on the surgical and radiotherapy aspects in addition. And if there is time, I'm happy to take questions at the end. And I see that there is a distinguished panel in addition. So I will move to the next slide. So briefly to talk about the history of neoadjuvant systemic therapy for breast cancer. Initially, it was to convert inoperable, locally advanced breast cancer to operable breast cancer. And that was from the 1970s onwards, when the early chemotherapy trials started to show that chemotherapy could induce a response in breast cancer. It became standard of care in that setting, and it was soon realised that there were more opportunities for neoadjuvant therapy for downstaging from mastectomy to breast-conserving surgery. This is in addition to the systemic therapy effect. And so this was consideration of just local therapy and assisting with the surgeon to conserve the breast and to do less surgery and achieve the same outcomes. Subsequently, there was a hypothesis that perhaps giving systemic therapy first, before surgery, may improve outcomes, which led to the NSABP B18 and B27 trials, which actually compared neoadjuvant therapy to adjuvant therapy. And unfortunately, there was no overall survival difference. The endpoint that was different, however, was the pathological complete response rate. And this indicated that the taxane component increased the PCR from 13 to 26%, which was a doubling, which was quite remarkable. And this was consistent with the adjuvant trial results. So the next hypothesis was that perhaps this could be an indicator of early treatment response that could predict for progression-free survival or overall survival differences. However, the Maori meta-analysis confirmed that there was no difference in survival outcomes across a number of trials. The caveat is that these were unselected patients. So at that time, we knew much less about subtypes of breast cancer that were more likely to respond to neoadjuvant therapy. And now I believe that with the subgroups that we treat, that we may be able to see a difference in outcomes with neoadjuvant therapy. We know that adequate local therapy is necessary, including surgery and radiotherapy if it's indicated, even if there's a clinical complete response or advanced imaging, because previous trials have shown that those with a complete clinical response, at least 25% will experience a local relapse and potentially a systemic relapse if surgery is omitted. So the concept that you can see here in this schematic is of neoadjuvant on the bottom line as a timeline compared with surgery on the top line, and indicating that the timeline is the same whether there is surgery first or surgery after chemotherapy, and that overall, on average, the relapse time or time to death of patients who do experience a relapse is the same for the average patient, but that we have an additional endpoint of PCR, which can give us more information. And this occurs quite early and can allow us to adjust treatment and to give us information on whether a patient is likely to do well or not early in the course, and gives us additional opportunities for both research and for altering the clinical course. We know that neoadjuvant therapy is increasing in use. It's supported by international guidelines, the St. Gallen guidelines, the North American guidelines. The Germans are particular advocates of neoadjuvant therapy, and there is FDA guidance on accelerated drug approval based on pathological complete response as a surrogate endpoint. 17% of patients with stage 1 to 3 disease in the United States, as per a publication from Mughali et al. In 2015, were receiving neoadjuvant therapy. And in Australia, around 12% in my region, which is an audit that I did back in 2015, and I expect that's continuing to increase, as that is the chart on the right at the bottom panel. However, the optimal proportion of patients receiving neoadjuvant therapy is actually not known, whether that is per subtype, for HER2 positive and triple negative, or overall, because it's still indicated for the ER positive subpopulations. These charts show comparisons both from the Maori meta-analysis and from a later meta-analysis by the Oxford Overview group published in the Lancet Oncology. And the Maori meta-analysis demonstrated absolutely no difference between neoadjuvant and adjuvant therapy. In terms of breast cancer mortality, the neoadjuvant group had a very slightly higher mortality, but that was not statistically significant. And as you would be aware with the Oxford Overview, they include a large number of patients. In this situation, 4,756, and that provides very good statistical power. You might also be aware that the Early Breast Cancer Trial Collaborative Group, the Oxford Overview, identified in that Lancet Oncology paper that there was a higher rate of local recurrence in the neoadjuvant group. So this indicates that adjuvant therapy is better for overall for the prevention of local recurrence. There is a significant caveat in this, in that this analysis was of all comers, which included trials that did not have optimal local therapy. And when the local therapy was optimized in that patients who required surgery, which is all patients who were operable, had surgery, and those who had radiotherapy had received it, who indicated, then there was less of a difference between the groups. There was still a difference. There was still an increased rate of local recurrence in patients who had neoadjuvant therapy. And I would like to think that now we have better imaging modalities and we're more able to select and determine which patients have a potential for local recurrence and to give better local therapy for those patients. Importantly, this did not, as we showed on the last slide, translate into any change in progression or disease-free survival or overall survival. So what are we doing with the with downstaging with neoadjuvant therapy? So historically, in a relatively unselected population, those who required a mastectomy initially, 1/3 could have breast-conserving surgery after chemotherapy. Of those who required breast-conserving surgery initially, 87% of those could have breast-conserving surgery after their neoadjuvant chemotherapy. Now that we know more about the subtypes, I would expect that the rate could be higher, with a larger number of patients receiving breast-conserving surgery if that is their intent. we know that there's an increasing rate of mastectomy even in patients who are eligible for breast-conserving surgery, and this confounds the results. So there would be a higher rate of patients who are eligible for a breast-conserving surgery, however, still go on to mastectomy, and that's a whole different talk. We see HER2 positive and triple negative more likely to experience pathological complete response and therefore more likely to be downstaged. In terms of prognosis, this is from Patricia Cortazar's meta-analysis from the Lancet in 2014 for the FDA, and this was what the FDA guidance was based upon, and indicates that in all subtypes there is a prognostic impact of neoadjuvant chemotherapy, particularly in the hormone receptor positive and hormone receptor negative and HER2 positive or triple negative subtypes. And I'll pull out triple negative as an exemplar. You can see that those patients who have a pathological complete response have an 86% 5-year survival. And that's actually very similar to the hormone receptor positive HER2 negative group. Whereas if they do not have a pathological complete response, then they have a 50% chance of a cancer recurrence within those 5 years. A hazard ratio of 0.24 is quite remarkable. But if we can't do anything about it, then it's the point is moot, because it merely means that patients know that they're going to do poorly. We'll get on to the meaning of that later. Overall, the estrogen receptor positive, HER2 negative have an 11% pathological complete response rate, but there are better ways of looking at the response. Grade 3 have a higher PCR rate, and double or triple positives, 30%, up to 50% with ER negative, HER2 positive. And beyond that, we're looking at up to 65% with HER2 targeted agents like pertuzumab, trastuzumab, and even higher in some of the trials that include some novel agents. So looking at the measurement of response, the CPS-CG is one that does a better job of looking at the estrogen receptor positive group, and that looks at clinical stage, pathological stage, whether a cancer is ER negative or grade 3, and then that adds to the score. And that is a significant differentiator comparing low versus high. Low score it correlates with a better prognosis after surgery. Fraser Simmons in 2007 developed the residual cancer burden score, and that has become in our region and in many international sites a standard reporting for neoadjuvant breast cancer specimens. It uses primary tumour bed size, overall cellularity, and the percentage of cancer that is in situ disease, size of the largest nodal metastasis, and the number of positive nodes. And that can be easily calculated on the MD Anderson website, and you can see the link here on my slide. And that shows a clear discrimination between the different levels of residual cancer, with the top of that slide, the Kaplan-Meier curve showing good outcomes in RCB 0 or 1, minimal disease left, compared with worse outcomes in RCB 2 and much worse in RCB 3. And this is exaggerated when you look at triple negative and HER2 positive, ER negative. So response-guided escalation of therapy has become very important over the last couple of years. In hormone receptor negative cancer, we know that some do well and some do very poorly. In the HER2 positive disease and ER positive disease, additional post-neoadjuvant therapy is used routinely in the form of endocrine therapy and trastuzumab. But for triple negative, additional therapy has not been routine. So can we improve those outcomes? So we've seen the Createx trial, which came out of Japan and Korea, for patients with operable HER2 negative breast cancer and residual disease after neoadjuvant therapy, and they were randomized to receive 6 months of capecitabine or observation or standard endocrine therapy. Relatively high dose of capecitabine, which is well tolerated by these Japanese and Korean patients. And then there was a subgroup analysis by estrogen receptor expression. And you can see in the full analysis set in panel A that capecitabine came out on top, that there was a benefit in disease-free survival. And then in panel C, there was an exaggerated disease-free survival in patients with triple-negative disease. And in fact, that's where the benefit lies, with a hazard ratio of 0.58 and a difference in disease-free survival at 3 years of 13.7%. Overall survival was a secondary outcome, and there was a significant benefit in the overall analysis set, but the triple-negative patients, once again, were where that benefit lies, with a 3-year overall survival absolute benefit of 8.5%. And in our clinical practice in Australia, and my understanding of clinical practice internationally, the triple-negative patients are the ones who are considered for post-neoadjuvant capecitabine. We move on to the HER2-positive breast cancer patients with the Catherine trial. And this took patients who had residual disease after neoadjuvant chemotherapy and randomized patients to ongoing trastuzumab versus a switch to TDM1. And that occurred after the surgery, and demonstrated that there was an 11.3% 3-year invasive disease-free survival benefit with a hazard ratio of 0.50 and a highly significant p-value. So this has led to regulatory approval of TDM1 and practice change internationally with the switch to TDM1. And furthermore, both of these trials have led to patients receiving more neoadjuvant therapy if they have triple-negative or HER2-positive disease. As I mentioned before, if you have a poorer prognosis, it is perhaps not comforting to know that, but if you have a poorer prognosis and you can do something about it, then that's a reason for making this change. I'll bring up a recent trial from Breast Cancer Trials, which is another escalation trial. And this is a trial where it was not randomized, sorry. It was a single-arm trial of triple-negative patients who did not have a good response, and they had more than 15 millimeters of primary breast tumour after 4 cycles of anthracycline. They were then put on weekly paclitaxel and had ipilimumab and nivolumab added. They then had surgery, and nivolumab was continued for cycles 7 to 15 post-operatively. There was regular imaging throughout, and this trial, the primary outcome was pathological complete response, and secondary outcome is overall survival and safety. This is a tolerable and deliverable treatment, although it does increase toxicity, and we are awaiting the results. There is the Penelope B Trial, which is looking at estrogen receptor positive HER2-negative patients who do not have a pathological complete response and a CPS-EG score of more than or equal to 3. And they were randomized to, following surgery and radiotherapy, to either palbociclib plus endocrine therapy or endocrine therapy plus placebo. And this trial is in the process of analysing their primary endpoint, and we expect to hear a result soon. And I'm suspecting, although I've not had confirmation, that this will be reported at the San Antonio Breast Cancer Symposium in December. Now, another option with patients who respond very well, as you can see in the right, with MRIs consecutively of a patient with a moderate-sized tumour that has completely disappeared apart from a mild blush of contrast within the breast, is that they may be able to have de-escalation. They may be able to have less chemotherapy because their cancer is very sensitive, or different and less toxic chemotherapy, fewer drugs than those who respond well to induction therapy, and potentially less nodal surgery. But we need to accurately identify those patients by using pathology imaging and genomics, circulating tumour DNA at baseline and ongoing. Another breast cancer trials study is the NEON trial, which has just opened, which is looking at nivolumab as a window, 2 weeks lead-in, followed by Nivo, carboplatin, paclitaxel, or the reverse with Nivo, carbo, paclitaxel starting, followed by Nivo, 2 weeks lead out, followed by surgery. This is a pathological complete response as the primary endpoint, but they will be followed for disease-free and overall survival endpoints. They are allowed to have anthracycline if they do not have a pathological complete response, and therefore this may lead to a larger efficacy trial of de-escalation in this triple negative population with moderate risk disease. So there are some potential risks of neoadjuvant therapy. There's less information about the axillary lymph nodes. We don't know if an axillary dissection can be omitted if there's complete clinical response in the axilla, and the accuracy of a sentinel lymph node biopsy is limited if fewer than 3 lymph nodes are retrieved. There may be a delay in surgery to remove the primary tumour, which is the source of the micrometastases, and that is of potential concern in patients who have chemo-resistant cancer. Patients may worry about the risk of progression whilst on treatment. However, according to an analysis out of the United States some years ago, this is rare, and I suspect that it's even more rare with better chemotherapy agents. And my point of view is that if the patient develops metastatic disease whilst on neoadjuvant therapy, then she was going to develop metastatic disease where the surgery occurred up front or was delayed, and that means that they would never have benefited from surgery in the first place and should not have had it. So neoadjuvant therapy is a good way of working out who should have surgery. And we've seen the results of multiple trials now, and one recently presented at ASCO showing no difference with a mastectomy or breast surgery for patients with de novo metastatic disease, even if they've had a response to chemotherapy. If progression is identified and the breast is still operable, then surgery is typically unchanged. Toxicity very rarely delays surgery. We know that clinical response does not correlate well with pathological complete response rate, even with good imaging such as MRI. We know that the tumour should be marked at the time of diagnosis to ensure it has been resected, because there is potential for local recurrence otherwise. Now, in terms of surgical considerations, marking of the breast tumour should occur at the time of diagnosis with either a clip, a carbon track, or a radioactive seed. So a carbon track is a very feasible option for localising a tumour. It's quite straightforward, and many sites in Australia do that. Others will use a metal clip. My clinical experience is to monitor patients with regular physical examination and history. And if there appears to be tumour progression, then an ultrasound can be done to determine if that's truly progression. I recently had a patient who I was giving neoadjuvant therapy to, and I palpated an increase in the size of the tumour, and then I sent her for an ultrasound and said, look, we may need to go for surgery. And as it turns out, she had an increased size of a benign cyst that was adjacent to the cancer, and the cancer had actually halved in size with chemotherapy. And so we then continued with chemotherapy. We know that surgery is required for all patients who are technically operable after chemotherapy, and that breast-conserving surgery is acceptable as long as radiotherapy occurs afterwards, and that margins are clear if there's no ink on the margin at the time of histopathology. The auxiliary considerations are that if the patient pre-chemotherapy is clinically node negative and is node negative at the time of surgery clinically, and then a sentinel node biopsy can be done, but that 3 nodes should be retrieved with a dual tracer technique with radioisotope and blue dye. If the patient starts out clinically node positive with N1 clinical disease and converts to clinical node negative after chemotherapy, then a targeted axillary dissection is an option with removal of the clip node and sentinel nodes, which may sometimes be the same node, may be different because the cancer tends to alter the lymphatic drainage. If a patient remains clinically node positive, then axillary clearance should occur. And if a patient is clinically N2 or 3 prior to chemotherapy, then an axillary clearance should occur irrespective of response. And if any excised node has cancer cells, and even in isolated tumour cells, then I would suggest an axillary clearance is indicated. We see neoadjuvant radiotherapy in some centres, but it hasn't become standard of care. Post-mastectomy radiotherapy and regional nodal radiotherapy based on pre-chemotherapy TNM stage. The B51 trial will hope to answer the question about whether patients who have a very good response need nodal irradiation. So patients have preferences about this, and they may sometimes prefer to go straight to surgery or have chemotherapy first. But a lack of response is associated with no difference in fear of cancer recurrence and no difference in anxiety or depression in some work that I published last year. Patients who receive neoadjuvant therapy have a higher satisfaction with the decision and less anxiety, even if they know that their prognosis is worse. And this has led to a freely available decision aid, so a decision support tool, which is available via the breastcancertrials.org.au website. You can see the URL there, and I would encourage you to consider that for any patients who would be interested in thinking about neoadjuvant therapy. So in summary, the neoadjuvant therapy is an option for larger, highly proliferative breast cancers, particularly the triple negative, HER2 positive, and grade 3 estrogen receptor positive. But it's also an option in lower grade estrogen receptor positive cancers who are interested in downstaging, because we still tend to see downstaging with chemotherapy in those patients. It's the patients who would require chemotherapy anyway, because we wouldn't tend to give chemotherapy to patients in the neoadjuvant setting if we don't think we're going to need it in the post-operative setting. And I would suggest that the full standard chemotherapy is given pre-operatively, so that if it's anthracycline and taxane, then all of it gets given pre-operatively, then surgery, unless they have problems with toxicity and then they or progression, then they go to surgery. If there's additional residual disease, then in triple negative or HER2 positive, then they should proceed to post-neoadjuvant therapy. Recommend marking of the breast tumour and consider marking of the axilla, and involvement of the multidisciplinary team early, preferably via a multidisciplinary team consensus conference discussion, and with patient involvement in the decision-making process. So with that, I will close. There's my email address if anybody wants to ask questions, and I'm not sure if we have any time for discussion at this point.